right, we will go ahead and get started. Good afternoon, everybody. I'm Jana Broughton. I am a quality advisor with Superior Health Quality Alliance. And joining me today are Jessica Henkel, Patty Leonard, and Amy Kaiser Magner. We are all quality improvement advisors with the Targeted Response QII team. And today is week 6, the final week of our infection preventionist work group. And today we're going to talk about how we put it all together. For those of you that have joined us for all 6 weeks, you will recall that in week 2, we kind of pushed some of Patty's slide deck where she talks about month end to this week. So we're going to kick it off with Patty and start off with kind of putting it all together with the month end. So Patty, if you want to go ahead and take it away.
All right, thanks, Jana. Welcome everyone again. If you think back when we were talking about the different audits and things that we do to evaluate the staff's performance and compliance, you kind of wonder what you do with all this data. And so you're going to need to calculate your compliance rates. You need to know how well you're doing. And in order to report it out to your QAPI, you're going to have to put some numbers to it. Are the slides going, Jana? There we go. All right. We can skip that one. So this slide talks about how to calculate for your rates of infections so that you know you can compare things month to month, and it gives you a quantitative number. Now, I do apologize. CDC had at one time a really cool video that would tell you how to calculate it. Jess is going to put a link in here. It's a Word document that does talk about how to calculate rates. I found it from the state of Utah, and it will give you more information on this. But in order to calculate your rates, you need to know your resident days each month. So that's the number of residents that are in a bed at midnight, and you do it for a month. So if you are a 100-bed facility, there's 30 days in a month. That will give you 3,000 resident days for the month. And then if you had, for example, 8 urinary tract infections for that month, you would divide 8 by 3,000, then you would multiply it by 1,000. So 8 divided by 3,000 times 1,000 gives you a rate of 2.67 urinary tract infections per 1,000 resident days. And that's kind of a fairly common way of calculating and comparing things. And you can do that same thing for your number of Foley's, your number of pressure injuries. Sometimes you will do an analysis of the number of urinary tract infections for only those residents that have Foley's, or the number of wound infections for residents that might have pressure injuries. So you can, work with the numbers, look for different things that you're possibly investigating, and then it will give you a quantitative number that you can compare and track month to month. So we can go on to the next one. So what do you do with this compliance data? Obviously, one isolated number doesn't really tell you anything. You need to compare it to previous. Maybe if it's a winter month, you're going to compare it to the previous month. Did you have more respiratory infections this month compared to a year ago? Sometimes for urinary tract infections, for example, you're going to compare month to month. But when you do identify a variance, you just can't leave it there. You just can't say, well, we had more this month. You have to do a root cause analysis. You need to ask questions. You need to determine the cause of this variance. And sometimes, you're going to, take the whys. You might do a fishbone diagram. You just need to have the conversations with the staff. This is something you just don't do on your own. Include all those persons that have information and have something to contribute and have some knowledge of what's going on. Oftentimes your frontline staff are the ones that are going to say, well, they changed the peri-care cleaners. So that's why no wonder we got more urinary tract infections. This stuff doesn't work. You will find out those kind of things from them, for example. But once you get all that information, you need to identify the cause of that variance, and then you need to implement a plan. If it was your peri-care cleaner, then you need to find a better product. Oftentimes it's education that you're going to implement for this plan. But then in the next month, you're going to see if your plan has been effective. And then if it's not, you're going to have to try something else again, dig a little bit deeper. So this is just all part of QAPI. It's all part of doing performance improvement. And that's what you have to do when you get your data and your information. You have to evaluate it to see if it makes sense. What story does it tell? So we can go to the next one. So that would be for outcome data, but what do you do with your process data? So that would be the results of your audits, those observations that you do of your staff. And this is simple math. You do 50 hand hygiene audits in a month, 45 were correct, 45 divided by 50 is a 90% compliance rate. But again, you take that number, you compare it to previous months, you look at what activities you put into place for that rate. If there's a significant variance, again, you're going to have to dig deep and talk to people and identify what the issues are. For hand hygiene, for example, do you have a problem that the dispensers are not being refilled? Is it a new product? Maybe it's really hard on the staff's hands. Does it smell bad? There's many different reasons why there could be a variance in hand hygiene, for example. It's not always a knowledge deficit. You need to look at other factors and then determine what you think is going on and put the necessary correction steps in place and then evaluate them on your next round of audits. So we can go next. So your month-end infection prevention and control report. A lot of facilities have a template. Most use some kind of a spreadsheet, but basically it's a summary of that data that you have correlated at the end of the month. You know, you put your results of your surveillance, but you need to also explain what that data told you, if there was a variance, and then also explain what your next steps are going to be. I like showing things in a graph. It's very visual because you need to share these results with your staff, and putting up a graph on the bulletin board for your staff will tell them very clearly if their compliance rates on hand hygiene are going up, if the UTI rates are going up. And that's something that they can easily understand. They can glance at rather than they're not going to read a real long paragraph explaining something. So you need to report out your process surveillance results as well as your outcome surveillance results and what those analysis means, and then your next steps. So your conclusions, what you're going to do, what's your next steps, so that the team knows when you come to the next meeting, they should be expecting you to report out on that as well. So this is just a little graph. These are things that I included in my IPC report. Is working as an infection preventionist. You know, when you do your analysis of your infections, you need to talk about, was there resident-resident transmission? Was there resident to staff transmission? Staff to resident, staff to staff, especially during COVID. That was really, really important that when we identified where the source of our infections were and how the spread occurred. You can also mention kind of in a summary or a little bullet point addendum to your report. Did you have a flu clinic? Did you do fit testing? What kind of education related to infection control did you provide that month? You can talk about, you know, changes to your hand hygiene dispensers. Did you purchase a new air purifier? Any education or communication with your families, changing signage? These are just different kinds of things that you could include in your report that talks about and shows your work to prevent the spread of infections in your facility. Surveyors like to read these things, but it does show that you're looking just beyond just doing the basics. And then what do you do with that report? Obviously, it needs to be presented to your QAPI team, and it needs to be noted in the QAPI meetings that the infection prevention and control, as well as the antibiotic stewardship reports were presented. Make sure that the medical director reads this report, get a signature somewhere. And oftentimes this information goes to your corporate IP, your vice presidents, and a lot of facilities, especially nonprofits or hospital-based facilities, have a board of directors. This information needs to be shared with them as well. and the administrators will know how to get that information to there. And then, as I mentioned, share the pertinent findings with the staff. They're the ones that are making the good things happen, that are making the improvements in compliance with things, pericare, they're instrumental in preventing a lot of your infections. So give credit where credit's due. So I threw up the next few slides. We've used them in several presentations. We started this series back last year with a bunch of new infection preventionists. So we just decided to include them this time, especially if you're new to the role, just maybe some suggestions that might help you get organized, help you know where your priorities should lay. I had lunch a few weeks ago with a group of infection preventionists in our area, and I asked them for tips. And they said a couple things. They said, get everything done early in the morning because you don't know what's going to happen throughout the day. So these things, in some cases, can be done, relatively in the first few hours of your shift. But I always used to check communications. That would tell me, residents that were sick, perhaps sent out to the hospital. You can check if you use point-click care or a lot of the other systems. You can look on the dashboard. What are the new antibiotic starts? And then when I made rounds, I checked with the charge nurses, I talked to the staff, I talked to housekeepers. But during your rounds, these are rounds that you're going to do for many purposes. You're going to observe the infection prevention practices. You can do some audits at this time. Check hygiene, check PPE, look at your isolation cards. If it's appropriate, you can provide some one-on-one education, but depending upon what the staff's doing, you might need to hold that till later when the staff has a few extra minutes. I know you're going to go to your morning meeting, but you can have information to present there, things to talk about concerning residents that you're worried about. And throughout the day, you can update your line listing report with the information that you got from your PCC dashboard and your rounds. You can do your 72-hour timeouts on your residents that are on antibiotics. You can pull up some lab results. And then when you're looking at your line listing and gathering your lab results, look for any patterns and trends. Are there things that you need to talk to the medical director about? Bring to the attention of the DON or the administrator. Then if you're necessary, you can look at some admissions to see if they have infection control needs. And obviously, when there's any changes in guidance, you need to kind of take that in, absorb it, and identify the implications to your facility and your team and be able to take that to your stand-up meetings to discuss next steps. And then weekly, I always track vaccines. So you need to know what residents, as we talked about, come in, need to get vaccines. And this is where you're going to double check and make sure that those vaccines got administered and where they documented it correctly. Do some audits to make sure that those things are being recorded correctly. You're going to someone has to do your NHSN reporting. Check your TB tests. Make sure that they're administered and read. I ran into this once. We had an issue with how we entered the orders into point-click care. They were getting given, but they never got read. So we quickly identified that issue. But I did some audits on that for a while just to make sure that we were staying compliant. And during the week, you're going to do some maybe other audits on are the nurses monitoring for adverse effects of your antibiotics? Are they monitoring for side effects of those antibiotics? Are they monitoring for any symptoms for urinary tract infections, doing COVID assessments, respiratory assessments, watching the residents for sepsis? So those are the kind of things that during the week you can do some audits on. And the group that I met with also did stress trying to stay up to date just as much as you can. And monthly, all policies and procedures have to be updated annually. This may not be your responsibility, but if they are updated by your corporate people, you need to know any changes to them. And if necessary, you might have to give a quick shift-to-shift in-service to your staff on any changes. So this is where you can talk about and provide information and education to your staff, whether or not it's at huddles, tape presentations, downloading a video for your staff to view, just talking, doing simulations. It just depends how your facility is set up and the capabilities that you have to provide education. But as Jana has mentioned, there are mandatory things that you need to provide you, the staff development, someone in your building needs to make sure that this infection prevention and control education is provided. And then keeping in touch with your ancillary departments, your dietary, housekeeping, laundry, to make sure that they're keeping compliant with all their infection control practices. And this is something that probably you're going to need to be talking about and planning for soon is your vaccine clinics. It's almost time to order your flu vaccine. So looking at your consent forms, getting your logs ready to go, just to be prepared so that you're all set so that you can get your flu vaccines administered in a timely manner. Then just other tips for success. Everyone, and I agree, teamwork. It's just not the infection preventionist's job to do infection prevention and control. It's the whole facility. It starts with the administrator and goes through every person in your building. Delegation, don't be afraid to talk with other department heads, other qualified staff to help you with the audits, to help you with the surveillance, to do some audit. If you have someone on light duty, teach them how to do observations. If you have a nurse that has a few minutes, then they can do some chart audits for you. It is a matter of prioritization and the ability to multitask. And I would say stay calm too. Don't get stressed out when you don't have this all done. It generally does take care of itself, but knowing that you have support of your leadership and keeping your DON, whoever you report to, up to date. If you do have to work the floor a lot, you're getting bogged down, speak up, let them know where you're at. Another suggestion, other facilities have had to have a backup person trained, just so if you can get a few days off, go on vacation, you're entitled to that. What if you get sick? There's a family emergency. Someone else needs to be able to step in and do the line listings, look at the McGears, do some of these audits, and just keep the records up to date. And the other major, huge suggestion is don't save anything just on your desktop. Because what happens if your computer crashes or, all of a sudden you decide to take a new job? This information needs to be accessible to other persons, whether or not it's on a shared drive. You print out hard copies, but it needs to be shared with other people so that this information is readily accessible. A lot of facilities get citations because there's a change in the IP or the leadership and the information is lost. It's not there. If you're missing 3 months, it doesn't matter if you have 3 months now, but if you're missing the 3 months prior to that, you're going to get an F880 citation. So just kind of to pull this part together, surveillance is one of the most important responsibilities of an infection preventionist, but you do that, you coordinate that. You're not solely responsible for it, but the look back and the surveillance is done real time, which is concurrently and retrospectively on the look back that you do on your chart reviews using your McGears, but it should tell the story of your facility, what happened, and then your analysis of what you believe happened, and then the action steps to improve the situations. That's all as important as the surveillance itself. But as we already stressed, it talks about you need organization and teamwork. You need support. So we threw in here as well some survey readiness tips and how to avoid citations. We've talked about many of these already, but here's a few more for you. To be prepared, we talked about being up to date, making sure your line listing is kept current, and having those monthly reports ready to go at the end of the month. Set some time aside each first or second week of each month to do that analysis, to pull things together. If you don't have an infection control binder, I do recommend that. And do mock surveys. Oftentimes corporate people will come into this. If you're part of a chain, sometimes you go to another building and do that. Use CMS's critical element pathway on infection prevention and control and immunization. And there's a link on the next slide for that. We also have the ability to provide an on-site infection prevention and control visit. If you've not had one, we contract with IPC Workgroup. I highly recommend it. They come into your building, they spend 2 to 4 hours, they make rounds, they go in every department, they teach as they go, they talk about best practices, and then they will provide you with a report that summarizes their findings and suggestions, as well as all the current guidance. So if you want a visit and have not had one, feel free to email any of us, put something in chat, and Jess or Amy can grab that information. It's one of the best, I think, the best things that we can do. Reports don't go to CMS or anyone. We get a copy, and then we also will go over it with you or send you recommendations and resources, but it is definitely free. To be ready for survey rounds, audits, feedback, prepare your staff, coach them, do those chart and care plan reviews and audits. And this is your entrance conference worksheet. This is a document that CMS provides. There's, I don't know, 30 some items that you should have ready for the surveyors when they walk in your building or within a day or so. Most facilities have a binder. I did. I had it tabbed just the way the worksheet lists here, but note under 29, it talks about infection prevention and control standards, policies, and procedures. Most buildings will give them the infection control binder, but know that these are the things they're going to expect upon arrival. Your surveillance plan, your antibiotic stewardship program documents, as well as whatever your policies and procedures on influenza, pneumococcal, and COVID-19 immunization. And that would be for residents and staff. And here's the link also for the critical element pathway for the infection control documents, as well as all the other critical element pathways are on that zip file as well. And quality measures related to infection control. Did you know that there were quality measures that related to infection control? I think sometimes we think it's all about falls and pressure injuries, but it's not. So there are quality measures and tracking that happen related to your hospital admissions, your emergency room visits. CMS tracks your UTI, your urinary tract infection rate, your pneumonia rate, and your sepsis. And this information comes a combination of things. The infections come from your MDS data, but some of the hospital information comes from Medicare billing documents. So it's not just all from one source, but this all speaks to, for your hospital visits, your sepsis screening and sepsis evaluation and recognition and treatment is going to be much bigger going forward, but we do have resources out there online. If you need help with the sepsis program, any one of us would be happy to help you. MDS diagnosis management and resolving diagnosis. Jana, I'm going to start this, but if there's something I don't get right, you can chime in. This is kind of Jana's baby. And tracking and being notified by CMS that rates of some facilities were elevated beyond normals for urinary tract infections, pneumonia, and sepsis. We did a little digging and talked to many facilities. And in the root cause, identified that a lot of the information that is going to CMS on your MDS is not current. Your diagnosis upon the resolution of an infection are not being resolved. So these diagnoses are being carried over. And so it looks like your rates are much higher because the diagnosis is carrying on for 6 months, a year after a diagnosis and an infection has been resolved.
Yeah, this is section I of your MDS. So if you utilize Matrix or PCC and you would like help auditing your data to see if your facility does have a coding concern, and what we've discovered in talking with facilities is that many facilities utilize the pull-through function of PCC from a quarterly to quarterly, for example, and they're skipping through section I without looking at diagnosis. So a diagnosis, for example, of pneumonia may sit on an MDS from the date that the patient was admitted with the diagnosis through until their next year's annual MDS, which results then in your pneumonia data getting kind of out of whack and wonky. Now, it doesn't affect your quality measures for pneumonia or sepsis, but UTI certainly will. And if you are in a state where they use case mix or diagnosis codes for payment for Medicaid, you could have an issue with billing for codes or upcoding so you certainly do need to correct those MDSs. And we can work with you on a one-to-one basis about how to run that report. I don't think a lot of IPs realize that MDS does have a function with your diagnosis of UTI, sepsis, and pneumonia, and that it is impacting your data.
So we do recommend, as another recommendation, that MDS coordinators, who I realize probably aren't on this call, but they need to work closely with the infection preventionist so that you're agreeing on the diagnosis. When a UTI is a UTI, and residents that come in from the hospital with that diagnosis, when things can be resolved out. So just kind of tuck that away, or maybe talk to your leadership about how you two can work better together. As well as, making sure that you're monitoring your trends and implementing your correction plans. That's what we've been talking all about here. And these are MDS coding and NHSN coding, and reporting also is something that CMS tracks. They track short stay and long stay measures related to your influenza shots and your pneumonia vaccines, as well as your COVID-19 vaccine. So these are all part of quality measures that are reported and tracked by CMS. And the surveyors are going to pull all this before they come into your building. So Jana, you're on.
Hi, good afternoon, everybody. So just in time, the neighbor pulled the barking dog back into the house. So the benefit of living in a suburban area, you get to hear everybody's backyard on a good day with your windows open. So we're going to talk about defining your role as a subject matter expert and a leader. I bet many of you don't think of yourselves as subject matter experts, but I want to share with you that we think of you that way. When you become an infection preventionist and that becomes your specialty, you are a subject matter expert, not only in infection prevention, but in infection prevention in your specific environment, your culture, your company, your organization. And because of that expert status, you may not realize it, you may not feel like you're a leader, but your staff, your floor staff especially, will designate you as a leader, as somebody that they're going to go to with questions or look to for solutions to issues that they may have around infection control, because you are that person that kind of leads and guides the organization through all things infection control. So really want to talk about defining your role as the infection preventionist. A lot of infection preventionists that we talk to wear a lot of hats. We recognize that this is a relatively new role. The regulations and the FTAGs around infection prevention became such a highlight during the COVID pandemic, and it put such a spotlight on the role and such a specialty on the role. But we were all doing it under like crazy circumstances of a pandemic, trying to get things in place and in order. And I know that now we're out of this pandemic and we're like, okay, now what? What do we do with all of this and how do I get organized? So first and foremost, we want to make sure that you understand the certification and education requirements for an IP, and that you recognize that you are a leader, that that is your role as an infection preventionist. You may not have staff that you supervise, but you are that manager and go-to of all things infection control. So first and foremost, have you looked at your job description? And does your job description have specific tasks identified by your facility policies and process? And have you ever really taken a deep dive into F882, which is the regulations around infection preventionists and what the requirement for your facility to have an infection preventionist is? And many facilities are seeing their policies and processes around the infection prevention role changing. They're becoming more specialized. The policies and processes may call out specific tasks from your job description. So I encourage you all to pull your job description. If you don't have one, if you've never seen it, ask for one. Say, okay, what's the infection preventionist? What's the expectations that our organization has for me in this role? And then what do the regulations state that my responsibilities are? And how does that mesh with how our facility policies and processes work? And I would encourage you to start thinking about yourself as that subject matter expert. You're the expert on all things infection control, the regulations, the expectations for your organization and facility. You are the leader of the infection prevention program, but you're not a standalone leader. As we've alluded to and we've talked about, it takes a team effort to conduct infection control and to really create an effective program for your facility. You probably didn't realize it until we had this conversation that you're a contributing member of the water management program and that you need to be at that meeting and you need to be asking questions and looking at the data from your water management testing, and how does your program work, and how does it, like for F880, is it meeting the requirements and what the regulations are requiring of it? You are a contributing member of QAPI. Your infection prevention minutes should be in every QAPI meeting. There should be a component of QAPI in your interdisciplinary team that meets to look at all things quality. You need to talk about that infection control data and ask for action plans and support from your team and get that interdisciplinary feedback and input on your infection control program. Obviously, education of infection control content and your program expectations around education. We've talked about quite a bit about education and training for infection control, and it needs to be multi-levels and multifaceted. And I think, Amy, this would be a good point to probably interject what you guys are going to be doing. What Superior Health, there's a team that Amy is leading from Superior Health. I hate to put you on the spotlight like this, but I just think it would be a good time for you to talk about that program and maybe drop the link in.
Sure, absolutely. So we are going to be initiating a new program. It's through CLIN 5, which is an annual education and training and competency program. And so what that entails is that we offer education, on-site education, where we would actually come to your facility. You are able to select from the topics that we provide, select the topics that you would like education for your staff on, and then either you can have the education provided online and then we come and validate the competency, or we can come to your facility and actually provide the education and validate competency. We also are going to be offering an escape room for infection control practices. So I will drop that link into the chat. And so what will happen is if you complete that form, it will return it back to us. I will reach out to you and just have a conversation. We can set up a time. I can explain the program in further detail, but we can set up a time and what would work best for you and your staff for us to come to your building, provide the education that you need. And then, like I said, validate the competency. These are the areas that we're seeing where most facilities are being cited in regards to their infection control practices, or it may be related to those core measures that you have to meet on an annual basis. So we just want to make sure that we're just providing you with resources that most facilities are having a challenging time completing, just because you're wearing so many different hats and you just it's hard finding time to get out on the floors to provide education and to validate your staff's compliance and competency. So we want to be able to offer that to you as a partner working with you. And I will put that link into the chat. And so take a look at that form. And then if you have any questions, you can always email me, or if you're interested, just fill out the form, send it back, and then I'll reach out to you within 3 days.
Awesome. Thanks, Amy. And I know this is an area that we have heard from many, many facilities across the 3 states of an area of need, that it's something that you're just not able to get to. It's one of those things that you're like, it's just another thing on my plate. And from a priority listing of things to get to, is probably not the top priority. And, you know, I'll be very honest. I know during COVID, a lot of facilities education became 100% focused on the high needs of the pandemic. And we relied on online content primarily, and a lot of staff competencies, hand-in-hand competencies, and the education for that competency kind of just dissipated and people forgot about it. So as infection preventionists, as a partner with you, Superior Health wants to offer this to you and your team. It is free. This is something that we provide as a quality improvement organization. So please consider taking this information back to your team and get this set up for you and your team to get this education completed. It's a great asset for you to be able to utilize. So finally, again, that subject matter expert, we call those SMEs in the research world and in the world of academia. And so I want you guys to think about yourselves as subject matter experts. You're subject matter experts on surveillance and reporting. I will tell you, in my 30 years of long-term care, if I needed help with a surveillance audit topic or what to look at, I often turned to the infection preventionist person in my building, because they were the person that knew how to calculate rates and how to set up audits and look at the data. And so I want you to think about yourselves as that and utilize that expertise to share with others on your interdisciplinary team for their own surveillance practices and auditing to really build up and beef up your QAPI program overall. So F882, and I just call this the fine print, it is based on the F tags from F880 to F945. So pay attention to the certification and education requirements. If you are a shared role in your building, make sure that the responsibilities of who does what are delineated between those roles. Don't just state that, well, it's myself and this person and we're sharing responsibilities. You need to make sure that that's delineated and understood, and that somebody in writing, it's in writing somewhere, is how you're going to break up the responsibilities of the tasks in the role. And the reason for that is twofold. One, if somebody changes or leaves, you have to delegate that to somebody new, correct? Or if something happens and you need to change some of those responsibilities, or it becomes too big and you need to, give them to somebody else, you know that something's not going to be missed. You're able to split that up. At the bottom of this is the SOM, that is the Appendix PP. That is where you find your F tags and all that fine print. You want to read through them. Interesting thing with CMS and the State Operations Manual, you don't just go to like F882 in the table of contents, you have to scroll through. So they are numerical. So F882 is probably mid to end of the SOM is where you would find those F tags. So kind of wonky in how you find them. All right. So now we're going to talk about related F tags, and that's the intersection of F838 and F880. F838 is, and I don't know how this slide got in here, but anyway, so this is the IPC reporting equality slide, so we'll jump through there. So F838 is the facility assessment risk assessment. And this facility assessment has come to light because of the staffing change that was announced by CMS, the staffing guidance, the new staffing role that's in much controversy right now. But as part of that rollout, they did roll out new changes to your facility assessment. As an infection preventionist, you may or may not know that your facility is required to do a facility assessment. As part of your facility assessment, there is a section called the Infection Control Risk Assessment. And basically, as part of your facility assessment, as part of your emergency plan, there's a risk assessment that your facility does based on certain risks to the residents in your building. The Infection Control Risk Assessment, which is a mandatory part of F838, it spells it out, that is an assessment that you are part of, or you should be part of, identifying the risks of infection or pandemics, endemics, outbreaks for your particular resident population based on location, prior history, prior data, and the types of residents that are coming into your facility or that you're admitting into your facility. An example for this would be a ventilator facility. If your facility is a ventilator facility, you probably have a higher infection control risk for respiratory infections based on the types of patients that you're taking in because they are ventilator or tracheotomy dependent. If your facility, for example, is in an area there has been high measles outbreaks, that would be something that you would want to identify on your infection control risk assessment. And this is your facility assessment. If this is confusing to you, I would encourage you to talk to your director of nursing, talk to your administrator, and ask to look at your facility assessment and look to see if your facility has completed an infection control risk assessment. And there's a couple of good examples out there. I believe Spice out of North Carolina, and we can send those to you if you need them. Again, just email us and we'll get you some links to the infection control risk assessment examples. But really, as the IP, it's your job and part of your expectation of your role to kind of know the history of your facility and to know your community. Is your community rural? Is it urban? What types of infections are you seeing for your health department? Is your health department identifying, for example, Southeast Michigan? We have a CORIS issue in Southeast Michigan. It's been an identified outbreak in a couple facilities. And so if you were a facility in Southeast Michigan in the counties of Oakland, Wayne, or Macomb, your risk for CORIS as an organism is probably higher than somebody in, let's for example, Northern Michigan or Upper Peninsula Michigan, where that's not been an identified organism. So it's utilizing State Department or State Health Department data, local health department data, your facility data, community data, to identify the risks for your residents in your building. So really F838 just kind of calls that out. And I just want to highlight that for you, that you should be part of the team that kind of completes that document. You should know what's in that document. And as things fluctuate and change, the document is a working document and it should be reviewed at least quarterly to make sure that the data is still accurate. I will share with you that back when this facility assessment first came out, pandemic risk was probably low for most facilities, and then COVID hit. And facilities were beginning to get cited for not keeping their facility assessment up to date because they were not identifying that, oh, hey, we're a high risk now. There's this COVID thing and it's everywhere. So, making sure that your data is up to date is really critical. And the facility assessment is used by the facility and the surveyors to make sure that you're taking care of the residents to their highest level of care, and you've identified the risks and how to mitigate those for your residents. A little bit more about that. So the infection control assessment and response ICAR is something that you should be doing annually. This is that facility-wide assessment to determine what resources are necessary to care for residents competently during both day-to-day and emergencies. And I think a lot of facilities forget that ICAR needs to be completed annually and it needs to be reviewed. So there is an ICAR link on the CDC that you can complete. It is an electronic ICAR. If you have not completed an ICAR with us in the past year, you can reach out and we can send you the links to that infection control risk assessment. I know in the states of Michigan, I believe it's IPRAT that still is doing this with facilities, IPRAT Sharps, and then Minnesota and Wisconsin also have departments that will come out and help you with this assessment. So just a few things to consider. For your infection facility assessment also, you need to make sure that on that risk assessment, you have identified your availability of PPE, your availability of current cleaning products, as well as fit testing for your staff. Those are going to be some questions that are going to be on that assessment. So as you're seeing kind of how things flow with your data and your surveillance and your education and your training, it's multifaceted. There's lots of pieces that you contribute to for your overall functioning of your facility. All right, so now that we've gotten through all of that, I'm going to take you out to the security. Actually, first, I'm going to skip the CDC website because it's wonky. I'm just going to give you the disclaimer right now that the CDC has changed their entire website. And so the links that we currently have on our website, 2 different CDC topics, are not functioning. Is that correct, ladies? That they're not necessarily taking you to the right pages currently? That's correct. Okay. So take a deep breath. We're all taking a deep breath. The CDC has changed their website in the past 2 weeks. So it's been a little bit of a treasure hunt for us also to see where we find things and what's still available and what's not. But if you are ever looking for a resource, please do not take your precious time to do that. Please reach out to one of us and we can get a resource for you. If it's something that you need right away, education, surveillance audits, different topics, we can find it for you because that's what we're here for. So please let us do that for you. But I do want to take you to a couple different websites. First, I want to take you to the Superior Health Quality Alliance website. I'm going to jump over to Superior Health. So this is our website. If you've not been here or you've not registered as on our email list, so this is where you would join to subscribe to our weekly emails. And this is a weekly update that you would get with upcoming educations, trainings, things to sign up for, and then new resources that we may have pushed out that would be coming to you weekly. If you are a facility that for some reason finds yourself in a directed plan of correction for F880 for infection control and the vaccine tag, or F880 at a high level, and you would like to work with us for your directed plan of correction, this is how you would get that process started. You come down here and you hit the start button, and that email comes directly to a group of us, and we usually respond pretty quickly. That email comes through to our phones. We get it. We've responded on a weekend to a facility that had a DPOC. So, and the work that we do with you for directed plans of correction is 100% free. So under the initiatives tab, you would go to the Quality Innovation Network Quality Improvement Organization. And here is where you're going to find a lot of our resources. So we have the Nursing Home Quality Improvement Collaborative. I'm going to click on this because this is a little bit more than just infection control. We have our vaccine information. We have real-time medical systems. If you're using that or you're more interested about that, you can look at that here. Here is Frontline Forces. This is our training modules. These are online training modules for those of you that do not have a training system or a learning platform for your staff. These are free learning modules that we've developed that you can utilize to assign to your staff to provide some of that education. And there are topics here that are more than just infection control. So I encourage you to explore that and look at that for your staff. Sometimes you have a staff member that you may have done a one-to-one counseling with, and you're like, I'd really like to give them some additional education. This might be a good way to assign them some additional education that's new learning for that individual. There's that DPOC again. And then here's the resources and all of the different information that we have. Again, we do more than just infection control as an organization. We do a lot of work on behavior management and antipsychotic medication use, which, as you know, is a hot topic with CMS. And there's information on that, including different action plans and research. Change of condition, there's a change of condition poster, chronic disease management, falls, incontinence, pressure ulcers, you name it. We do a lot of the work on it. And then mental health and behavioral health and long-term care. Here is the infection control, infection prevention and control information. These are all the pages with the different resources that we have, surveillance tools, copy tools, educational materials, links for multiple different organizations. Anything that we have on our website was free sourced or created by Superior Health. So if you need a resource, this is a really good place to come and get that information. And then NHSN, if you are somebody that is new to doing NHSN and you want to get a tutorial on that, we do have a test environment. We can work with you on your NHSN reporting and walk you through how to pull reports and how to look at that data. Here's information on your quality measures and your 5-star calculation, how to calculate your 5-star rating. And then here are QAPI tools. So I encourage you to look at this if the QAPI is new to you. We have this root cause analysis toolkit, which is excellent. Gives you a fishbone diagram, gives you a 5 whys. It talks you through how to think about root cause and then how to develop an action plan template. So if you have, for example, a new avoidable pressure ulcer in your building, you're like, oh my gosh, we need to root cause how this happened. We need to develop an action plan for that so that we can make sure that this doesn't happen again. Here's your tools. So you can go right here and get them and you don't have to recreate anything. And then we have already worked through some action plans for you, and here they are. So these give you tips and tricks and things to consider for an action plan development. There's just a plethora of information on our website. I don't know how to describe it, but the website itself, once you get in, if you start clicking on things, you'll find it. It's just not necessarily super intuitive, but I like to just share it with folks so they get an idea of what the website looks like. Okay, the next one is one that, I think people forget that it's out here, and this is the Q-Core. And what the Q-Core is this is where all the survey data from every single nursing home in America gets tabulated and stored for public consumption. So this data, I think it gets updated quarterly. It's not always the most up-to-date, but it is more up-to-date than Nursing Home Compare. I will share that with you. Now, the downside of this is I can drill down and see what F tags facilities have received. And we do that as an organization to look for trending across F880 in different areas in the 3 states. We do that for a couple reasons. One, so that we can develop education specific to the needs of the facilities, but 2, to really let facilities know, hey, we're starting to see this being tagged, or this is something that they're really focusing on. You might want to pay attention to this and start looking at this from an education and copy perspective. So to go in and see your nursing homes, you would come over to the left and you would click on nursing homes. And you're going to come up with all these different reports. Now, you can go through and find yourself, but I like to use the deficiency count or the citation frequency. So let's look at citation frequency. And we're going to look at fiscal year 2024. Now you need to remember that fiscal year in the government starts October 1st, I believe, September 30th, October 1st. It's a wonky year. It's not January to January. So we are in the middle of 2024 already, probably in the coming up on the third quarter of 2024. And then you can drill down for different regions. And these are CMS survey regions. And we are in the Chicago region. So Michigan, Minnesota, and Wisconsin are in region 5, which is Chicago. And then we're going to look at, we're going to run the report. And then this report will tell us the top citations for our region, which includes Michigan, Minnesota, Wisconsin, Illinois, Ohio, and Indiana. We represent only 3 of those states. So this is all 6 states combined. But nationally, I will tell you that F884 is the #1 tag nationally, and that's the failure to report NHSN data. And that continues to be the top citation nationally. But if you look down here on F880, and we go down, F880 is number 3 in our region. So infection control continues to be a high level tag. And if we click on F880, this is where it tells us every facility that has had that tag since fiscal year 2024 has started. So we'll pick on a state that's not one of the 3 of us, so we can do that. So we'll go to Illinois, and we'll look at the Illinois citations. And you can see this is the number of citations in the fiscal year that these facilities have had. So what I look for when I'm looking at data and looking at facilities that might need support, I go to facilities that are anomalies. So as I'm looking through Illinois, I can see that, golly, we have a lot of facilities with a 2, but here's a facility that's been tagged 3 times in 2024 for infection control. They're probably going to be a facility that we're working with or we would need to work with, or that could use some support. So if you click on it, you can see the dates that those facilities, the tags that they've received, and the scope and severity of the F tag. So as an infection preventionist, how would you use this? Well, I would use this data to look at what my survey team is citing in my area. Now, a couple things that you can do to do a drill down on this. If you have facilities and you drill down to like 5 facilities and you see that they're being tagged on F880 at a high level, that is when you could go to your state specific licensing website. Michigan, Minnesota, and Wisconsin all publish the actual 2567 data. Wisconsin and Minnesota actually publish the plan of correction that you submit along with the 2567 data, and that is all, again, publicly available. So your F tags, the 2567, your plan of correction in Minnesota and Wisconsin are publicly out there. So just data. I love data. I think it tells us good stories. It tells us a lot of things, and we can really train ourselves to begin looking at that to kind of do our focus on what areas are trending. And normally when we see a trend on a specific topic within infection control, that tells us that there's a couple things going on. One, that there's a gap in knowledge possibly, or there's something else going on in our states that we need to focus on. I would expect that enhanced barrier precautions are going to start being rolled out with F880 tags specific to EBP. So far, we're hearing that the state surveyors are hit and miss with tagging enhanced barrier precautions. We're not seeing it entirely the focus of F880, but I would guess that by the end of the summer that we're going to start to see more of the focus on F880. So that is the Q core. Is there any questions anybody has about the resources that I just shared? Go ahead and unmute yourself if you have a question. No questions? A lot of information. When is NHSN reporting going to end? So here's the deal. Certain aspects of NHSN are due to sunset in September. However, with the addition of NHSN vaccine data, with that being written right into the regs, we anticipate that it's going to continue. I hate to be the bearer of bad news. We have not heard an update. We have heard nothing, but COVID data did not end in May of 2024. We don't believe it's going to sunset in September. In fact, the regulations have been updated around it, but nothing from the CDC on NHSN. So we're just awaiting for CDC and CMS to get together and figure out what they're going to do with it. but all things look like NHSN is going to be a continuous thing for nursing homes. So
I think
unfortunate. Yeah.
we have another question back there about UTI diagnosis.
Is that the one? I think Jessica answered that. If a resident is admitted from the hospital with a diagnosis of UTI, but does not meet the criteria, does that need to be coded on the MDS if we utilize NHSN criteria for determining UTI? Yes. Jessica's going to send out that presentation that talks about coding. So here's the weird thing. MDS and IPs look at things a little differently. MDS is coding on admission for a Medicare short-term stay. They're coding for coverage and for reimbursement. We'll be very honest about that. MDS, that's their training. They are how you get paid by CMS. So they are going to capture every diagnosis, every illness, every issue that you might be treating a resident for is going to get utilized on that MDS. If you have questions about the MDS specifically as an infection preventionist, I'd really encourage you to look up the MDS specifics. It's free online and it talks about coding. Jessica, I'm trying to remember the name of that document. What is it called? It's the document that walks you through how to code your MDS. And it's there's
The resident assessment instrument, RAI.
Yeah, there you go. Thank you. Thank you. I'm like, I'm having drawn a blank. I was calling RAC and I'm like, no, it's a RAI. So if you look that up online, it will walk you through the specifics of different item numbers in the MDS and how to code it. So there are instances where you may not own an UTI as a facility acquired infection, and it may not hit your surveillance data, but it will be on your MDS for a short-term diagnosis if they're getting treatment for it or were treated for it during the look back period. Am I answering that correctly, Jess?
Sorry, I was looking for the link to the RAI manual.
It's okay. I was talking about the look back period for UTIs because on admission, there is a look back period. And if that urinary tract infection happened in that look back period, they may code that on admission, but it won't count as a facility acquired infection. What about infection control committee meetings? If we're reporting in QAPI and meet on a PRN basis, am I covered? Julie, that's a great question. As long as your minutes and you can prove that you have infection control committee meetings and it's not a committee of one, but it's an interdisciplinary committee and that you're reporting in QAPI and that you're doing some type of surveillance and that data is being looked at, it should be sufficient. You have to have a robust. So I would look at F880 and make sure, are we, look at your data for your facility. Are your infections really low? Are your rates great? Then, yeah, what else could you do? I mean, is your water management plan being reported off to your QAPI? What other areas are you looking at? Your staff education complete? There's a lot of things that you can utilize to look at from process data for infection control. A good one is staff vaccination questionnaires. Every state has a different rule, so I'm going to preface that by saying it. Utilizing Michigan, for example. In Michigan, it is a state rule that you ask your staff about their childhood vaccination status, and that somewhere it is documented in their employment record about their vaccines. It doesn't mean that you have to offer them. It doesn't mean that you require them to have those vaccines. It simply means that you have asked them about it and provided them education about vaccinations. So that also is part of F880 that you need to ask that question. Have you ever looked or have you ever had HR look to see, have you done that with your staff? Is that something that you've done when they were hired? Weird anomaly. Rarely see it come up on an F tag, but where I do see it get tagged is when you have staff, when you have an outbreak of like the measles, for example, you're definitely going to get that looked at. Facilities in Illinois recently, because of the Chicago outbreak with measles, nursing homes in Illinois were scrambling to get education and vaccines for staff who have never been vaccinated for measles or to get proof that they've had a vaccination. So those are the types of things that like really, really, really low hanging fruit. But as an infection preventionist, it's something that you might want to ask somebody to audit for you. So Any questions anybody has? All right, we are almost at time. So here's a little slide about how to get it all done. First and foremost, take a deep breath, and just make sure that if every day is going to be an adventure. So keep an open mind, find your patience. So questions and takeaways. What is on your to-do list? What have you learned? And can you give us some suggestions for the next group of IPs? I want to say thank you on behalf of the 4 of us. You guys have been really interactive. You've been a great group. This is the biggest group that we've done this with. And I am just so impressed that you're all here week after week. And we hope that the information has been helpful to you and that you've gotten some nuggets of new information and new things that you can utilize in your day-to-day work. Here's how you can continue the conversation. Here's how you connect with us. And then I have to give you this slide because this is a requirement by CMS to share with you that the views expressed in this material do not necessarily reflect the official views or policies of CMS or HHS. So, any questions anybody has? If not, it has been an absolute pleasure to meet all of you. We hope you take the evaluation. And in that evaluation, if you could please add any suggestions that you have for the 4 of us, for the next group that we perform this with, or any areas that you would like Superior Health to provide additional education or training in the future on, please drop that also in the evaluation or send us an email and we're happy to help. So thank you, everybody.